Hello students, I am Dr. Harini, Assistant Professor, Department of Conservative Dentistry and Endodontics, Vinaga Mission Shankaracharya Dental College, Salem. Today we are going to see the topic Antibiotics in Endodontics. These are the contents of my presentation: introduction, followed by definition, history, classification, local and systemic uses of antibiotics in endodontics, recent advancements, conclusion. Introduction. So generally the endodontic infections are usually polymicrobial. So antibiotics are preferred sometimes to control the bacterial spread, but mostly localized to pulp and periapical conditions, does not need them. Overuse is a concern because it increases the risk of antibiotic resistance and side effects. Current guidance from endodontic societies emphasizes the careful evidence-based prescribing to avoid unnecessary usage. So what are antibiotics? Antibiotics are the substances produced by microorganisms which selectively surpasses the growth of microorganisms or kill them at very low concentrations. Antimicrobial agent, these are the agents which are available synthetical as well as naturally obtained drugs that attenuate the microorganisms. Chemotherapy, these are the treatment of systemic infections with specific drugs that selectively surpass the infecting microorganisms without significantly affecting the host. Antibiotics in endodontics. Antibiotics in endodontics are used as an adjunct, not as a substitute, for proper endodontic treatment such as drainage, debridement and root canal therapy. They are mainly indicated when infection is spreading, there is a systemic involvement or the patient is medically compromised. History. The antibiotics generally arise from three major phases. One is the Eldritch phase, followed by the empirical phase and the modern era of chemotherapy. Eldritch phase. In this phase, some of the naturally occurring trees extract has been used, in which the moldy curd by Chinese for the treatment of boils, Kalmoga oil for epilepsy, Chenopodium by Aztecs for intestinal worms, Mercury by Paracelsus in the year 16th century for syphilis, Cinchona bark in the 17th century for fevers. Coming to the Eldritch phase, this gives an idea if the certain drugs could selectively stain the microbes, they could also be selectively toxic to those organisms. He tried methylene blue, tryptan red, etc. He also tried the asphenamine in 1906 and neoasphenamine in the year 1907 for the treatment of syphilis. He coined the term then chemotherapy. Coming to the modern era, Domark in the year 1935, he started the therapeutic effect of Prontosil, followed by Pasteur in the year 1877, demonstrated the phenomenon of antibiosis, that is the growth of anthrax bacilli in urine was inhibited by airborne bacteria. Fleming in the year 1929 discovered penicillin. Shane and Florey in the year 1941 used the clinical usage of penicillin. Waxman and his colleagues in the year late 1944 discovered streptomycin. Coming to the classification of antibiotics. Although antibiotics are present in wide range, they have been categorized based on their different criteria of functioning and modalities. They are based on chemical structure, mechanism of action, type of organism against which primarily active, and spectrum of activity. Coming to the mechanism of action, it has been categorized into factors such as inhibiting the cell wall synthesis, which includes the drugs like penicillin, cephalosporins, vancomycin and bacitracin. The other, causing leakage from cell membranes like polypeptides such as polymyxin, colistin and polyenes, including nystatin and amphotericin B. Inhibiting protein synthesis includes tetracyclines and chloramphenicol. And coming to the macrolides like erythromycin, clarithromycin, clindamycin and vancomycin. Misreading of mRNA including the aminoglycosides. Inhibiting the DNA gyrase includes the fluoroquinolones and interfering with the DNA function, example rifampicin and metronidazole. Interfering with the DNA synthesis like acyclovir, zidovudin and edoxuridine, and interfering with the intermediary metabolism like sulfonamides including ethambutol. Coming to the based on type of action. Type of action is classified into two categories based on the action of the antibiotic towards the specific organisms, followed by bacteriostatic, which are the bacterial killers, and bactericidal, which are the growth inhibitors. Bacteriostatic involves sulfonamides, erythromycin, tetracycline, ethambutol, chloramphenicol and clindamycin. Bactericidal includes penicillins, cephalosporins, aminoglycosides, vancomycin, metronidazole and cotrimoxazole. So coming to the characteristics and properties has been classified into bactericidal and bacteriostatic based on the different characteristic phenomenon. First, the primary action of bactericidal, that is kills the bacteria cell directly, whereas in statics it inhibits the growth, division and replication. Coming to the target mechanism, the bactericidal group of drugs inhibits the cell walls, cell membrane and critical nucleic acid structure, whereas bacteriostatic drugs targets the protein synthesis, subunits or metabolic pathways. Coming to the immune dependence, these are bactericidal drugs are less dependent on host immunity, preferred in immunocompromised patients specifically. Bacteriostatic in this immune dependence is entirely dependent on the functional host immune response to clear the infection. Coming to the effect of drug removal, the bactericidal drugs action is irreversible, bacteria remains dead. In case of bacteriostatic, action is reversible, bacteria can resume growing if the drug is withdrawn prematurely. Coming to the endodontic relevance of both bactericidal and stat. In case of cidal drugs, the first line of defense like amoxicillin and metronidazole selectively targets the cell wall and DNA of anaerobic biofilm pathogens. Bacteriostatic, that is the second line, used primarily when beta-lactamase allergies prevents the bactericidal options. Coming to the based on type of organisms against which it is primarily active. These are classified based on the organisms against primarily active one. Example, antibacterial like penicillins, aminoglycosides, erythromycin, etc. Antifungal including amphotericin B, ketoconazole. Antiviral including acyclovir, amantadine, zidovudin, etc. Antiprotozoal drugs like chloroquine, metronidazole, diloxanide and anti-helminthic drug including mebendazole, niclosamide. Depending upon the spectrum of activity, they has been classified as broad spectrum, narrow spectrum and extended spectrum. Narrow spectrum includes penicillin G, streptomycin and erythromycin, and broad spectrum includes tetracycline and chloramphenicol. Extended spectrum includes ampicillin and amoxicillin. What are endodontic infections? The endodontic infection is defined as the infection of dental pulp and periapical tissues, that is the tissues surrounding the pulp, root tip and the pulp of a tooth. These infections are fundamentally polymicrobial, meaning they are caused by complex community of diseases of bacteria working together rather than a single type of organism. Under normal conditions, the internal root canal system of a healthy tooth is completely sterile, protected by the dense structural layers of enamel and dentin. An endodontic infection begins when the protective layer, that is the enamel and dentin, fails, allowing oral bacteria to invade and colonize the tissue. How endodontic infections are developed? So it develops as a sequence of events following from the infecting the healthy sterile pulp. Pulp is defined as the healthy vascularized internal tissue of the normal tooth. First, the infection starts from the protective barriers like enamel and dentin and reaching out to the intact sterile pulp, after which the bacterial invasion happens through the deep caries, trauma or structural cracks, following which pulpal necrosis happens after the bacteria invading the healthy pulp. In this, the pulp loses its blood supply and dies, followed by apical periodontitis, which is a periodontal problem in which the bacteria exits the apex and destroying the surrounding bone of the root tip. How endodontic infections develop? It arises from the sequence of events, following which the first one is the portal of entry through the deep dentinal caries, that is the tooth decay, fracture, cracks or severe trauma exposing the underlying dentinal tubules. Bacteria use these microscopic channels as physical highways to migrate towards the center, that is the core of the tooth. The step 2 involves the pulpal response and ischemia. As the bacteria approaches the pulp chamber, the tissue mounts an inflammatory response which is called the pulpitis. Because the pulp is trapped inside the chamber made of dentin, inflammatory swelling increases the internal pressure. So here, this is the tooth, this is the pulp chamber followed by the root and pulp. This is the pulp, which is the vascular structure. In this, the pulpal response and ischemia, here there is a deep caries here. When this caries reaches the chamber of pulp, it loses its vitality, followed by the blood vessels here, it got constricted and followed by the inflammatory swelling happens surrounding the tooth, which is caused by the internal pressure in this pulp chamber. So this pressure compresses the microscopic blood entering the root tip here and cutting off the blood supply. Necrosis, that is tissue death. Deprived of blood flow, the pulp tissue dies, that is necrosed. Once necrotic, the root canal system becomes warm, moist and dark and entirely avascular. Because of this, the body's immune cells can no longer travel through the bloodstream into the tooth, so the root canal turns into ideal uninhibited sanctuary for blood proliferation and biofilm formation. Followed by the periapical extension. So it is unable to be stopped by the host defense. The bacteria and their byproducts such as lipopolysaccharides travel down the root canal and exits through the apical foramen. This is the root. This have two entries. This is the accessory canal and this is the main one. So this is the main opening, and through this which deep caries followed by apical periodontal region affects, and followed by through this opening the lesion overgrows and this surrounding bone is also affected. So this triggers an inflammatory reaction surrounding the jawbone, also known as the apical periodontitis. So coming to the selection of antimicrobial agents. The antimicrobial agents can be selected based on some identities such as the organism's identification, patient factors, site of the infection, the organism's susceptibility to a particular agent, safety of the agent and cost of the therapy. Selection of antimicrobial agent according to some clinical scenarios. So first scenario includes healthy patient with spreading localized anaerobic infection. In this, preferred antibiotic is empirical narrow spectrum bactericidal antibiotic, that is amoxicillin, which can be given as an oral delivery. Scenario 2, the patient with a confirmed true penicillin anaphylaxis history. Penicillin anaphylaxis is nothing but allergic to penicillin, which is not supported by the patients who are taking penicillin. They will be developing some allergic reactions which are known as anaphylaxis. So here the preferred antibiotic used is non-beta-lactamase alternative, which matches the pathogenic profile, which includes clarithromycin and azithromycin. Coming to the scenario 3, the immunocompromised patient with systemic infection symptoms. Here broad spectrum strictly bactericidal and high bioavailability drug, that is co-amoxiclav or IV broad spectrum regimens. Scenario 4, confirmed infection by a strict obligate anaerobe. Here the targeted anaerobic cidal agent which disrupts the DNA synthesis, that is the metronidazole, is prescribed. Bacteriology. Generally the pulpodentin complex is sterile. The bacterial infection of the dentinal tubules occur more often and more rapidly in the non-vital tooth than in the vital ones. So bacteria from the distance towards the pulpal host pulpal response. What are all the scenarios happening here? Distal dentin that is more than 2 mm away leads to sclerotic and reparative dentin. Deep dentin that is less than 2 mm away leads to chronic focal inflammation and frank pulpal penetration, which leads to micro abscesses or total necrosis. Coming to the classification of endodontic infections, they are broadly classified into intraradicular, which is occurring inside the root, and extraradicular, which involves the surrounding circumferential area of the root, that is involving the periodontal tissues like bone, cementum and periodontal ligament. Intraradicular, they are subclassified into primary, secondary and persistent. So when to prescribe systemic antibiotics in endodontics? In case of symptomatic or asymptomatic apical periodontitis, in this case no antibiotics are needed, debridement is sufficient. Coming to the acute apical abscess, in case of systemic involvement or in immunosuppressant patient, here local debridement and strict systematic antibiotics are needed. Only apical abscesses, no systematic antibiotics, but debridement of root canal is needed with proper intracanal medicament to be placed. Coming to the cellulitis or space infection, which is somewhat a serious condition in which it involves all the spaces in the facial area, here the systemic antibiotics is definitely needed. Coming to the commonly used systemic antibiotics in endodontics. Penicillin V, we as all know, it inhibits the cell wall synthesis by inhibiting the transpeptidase enzyme, and a loading dose of 1 gram penicillin V should be orally administered, followed by 500 milligram for every 4 to 6 hours for 5 to 7 days. Amoxicillin, analog of penicillin, it is inhibition of biosynthesis of cell wall mucopeptide during bacterial multiplication, which are effective against gram-positive and gram-negative organisms. The usual dosage of amoxicillin is 1 gram loading dose, followed by 500 mg for every 8 hours for 5 to 7 days. Augmentin, this is a combination of amoxicillin and clavonate, which carries amoxicillin of 500 mg and clavonate or 125 mg. Clavonate is a competitive inhibitor of beta-lactamase enzyme produced by the bacteria to inactivate penicillin plus cell wall synthesis inhibition by amoxicillin for both gram-positive and gram-negative. Usual oral dosage of amoxicillin is 1 gram loading dose followed by 500 mg every 8 hours for 5 to 7 days. Clindamycin, lincomycin, these are the protein synthesis inhibition in bacteria binding to 50S ribosome for gram-positive facultative microorganisms and anaerobes also containing certain gram-negative organisms. Oral adult dosage for serious endodontic infections are 600 mg loading dose followed by 300 mg every 6 hours for 5 to 7 days. Clarithromycin and azithromycin macrolides, they act by inhibiting the protein synthesis in bacteria binding to 50S ribosome. They act in both gram-positive and gram-negative organisms. Oral dosage of clarithromycin is 500 mg loading dose followed by 250 mg for every 12 hours for 5 to 7 days. The oral dosage of azithromycin is 500 mg loading dose followed by 250 mg OD for 5 to 7 days. Doxycycline, tetracycline. These are bacteriostatic drugs inhibiting the protein synthesis by binding to 30S ribosome, gram-positive and gram-negative microorganisms. They are available in 100 mg drugs which are given BID. Ciprofloxacin, a synthetic fluoroquinolone. It inhibits the enzyme bacterial DNA gyrase which acts as bactericidal drug. These have potent activity against the gram-negative bacteria but very limited activity against gram-positive bacteria, not effective against anaerobes. They are given as 500 mg at every 12-hour interval. Metronidazole, which is a nitroimidazole group, these possess redox reaction releasing the free radicals. They are effective against the anaerobes. They are given in the amount of dosage of 250 to 500 mg QID, which is 4 times a day. Duration of antibiotic therapy. The duration of antibiotics has not been defined precisely, even though dental practitioner considers the bacterial infection requiring a complete course of antibiotic therapy. A general tendency to administer an antibiotic is definite for about 3 to 7 days as needed. Since prolonged antibiotic usage destroys the commensal flora, that is the normal flora of the oral cavity and other body sites, and terminates the colonization resistance. There is a common misconception that prolonged antibiotic administration is necessary even after the clinical remission of the infection in order to avoid rebound infection. So, endodontic infection usually do not rebound when the source of periapical infection is properly eradicated, which is complete debridement, irrigation and disinfection of the infected root canal. The only guide for determining the effectiveness of antibiotic therapy and local endodontic intervention is the clinical improvement in the patient's symptoms. Principles of antibiotic prophylaxis. So, generally prophylaxis is the term used for prevention of such diseases. So, satisfactory risk and cost benefit ratios should exist which is benefited to the patients. Significantly, it should outweigh the medical and the financial risk. The antibiotic must be in high concentrations at the target site. An antibiotic loading dose, that is 2 to 4 times the maintenance dose, must be used. The antibiotic is continued as long as microcontamination from an operative site continues. So, the commonly used antibiotics in oral infections, that is the dosage for prophylaxis, are penicillin V 250 to 500 mg 4 to 6 hourly 5 to 7 days, amoxicillin or amox with clavonate, that is the augmentin 250 to 500 mg for every 8 hours 5 to 7 days, clindamycin 300 mg to 600 mg for every 6 hours for 5 to 7 days, metronidazole 200 or 400 mg for every 8 hours 5 to 7 days, and followed by azithromycin 250 to 500 mg once daily for every 5 to 7 days. So, this is the main sequel of endodontic infections for a particular patient in which the antibiotic recommended for symptomatic endodontic patients. In case of vital pulp and pulpal necrosis and acute apical periodontitis, antibiotics are generally not recommended in which the debridement is sufficient. Coming to the pulpal necrosis and acute periradicular abscess, here these are categorized into subgroups localized and spreading. In case of localized, antibiotics are not recommended. Consider antibiotics only if the patient is medically compromised. But in case of spreading type, antibiotics recommended to supplement the local treatment, that is considering the penicillin V or amoxicillin 500 mg QID or clindamycin 300 mg QID for patient if allergic to penicillin. Coming to this, if this condition resolves, condition does not resolve and condition deteriorates. If condition does not resolve, there are two options like consider culture and sensitivity testing or switch to clindamycin macrolide or cephalosporin or add metronidazole to the penicillin. If the condition deteriorates, consider prompt referral to the surgical specialist. Local antibiotics in endodontics. Triple antibiotic base. So, it includes 3 types of antibiotics, namely metronidazole, minocycline and ciprofloxacin. Metronidazole 500 mg, minocycline 100 mg and ciprofloxacin 200 mg is taken in the ratio of 1:1:1 for 3-mix formulation. This is introduced by Hoshino et al. Since the root canal infections are polymicrobial in nature and because of the complexity of infection, a combination of antibiotic is needed to address the diverse microflora. The carrier is propylene glycol and macrogol ointment in 1:1 ratio. This formulation was later modified by Takushige et al. As metronidazole, minocycline and ciprofloxacin mixed in the ratio of 3:3:1. Triple antibiotic paste is shown to be cytotoxic to human periodontal ligament fibroblast and it causes exacerbated inflammatory reaction in subcutaneous connective tissue, and minocycline component causes discoloration of the tooth. MTAD, it includes doxycycline, citric acid and detergent. Doxycycline 4%, citric acid 4.25%, detergent that is polysorbate tween 80. MTAD is able to remove the smear layer without affecting or altering the structures of dentinal tubules. Study by Newberry et al. Demonstrated the antimicrobial efficacy among MTAD against 8 strains of E. faecalis. Here MTAD was used as final rinse for 5 minutes after irrigating the canal, initially with 1.3% sodium hypochlorite. This showed complete elimination of 7 out of 8 strains of bacteria. TerraClean, this is a mixture of antibiotic, acid and detergent, but it differs from MTAD by the concentration of doxycycline, that is 50 mg per ml, and the type of detergent polypropylene glycol. TerraClean is more effective than MTAD against the endodontic pathogen. Odonto paste. Odonto paste is a zinc oxide based root canal paste with clindamycin hydrochloride and 1% triamcinolone acetonide formulated and developed in Australia. It is a bacteriostatic and prevents the bacterial repopulation in root canal system. Ledamix paste, it is used as both pulpal capping agent and an intracanal medicament. Ledamix paste is a combination of 3.2% demiclocycline hydrochloride and steroid 1% triamcinolone acetamide in polyethylene glycol base. Steroids mainly reduce the inflammation and pain, while the antibiotics limit the infection by the microbes. Ledamix combination of 0.7% triamcinolone, 3% demiclocycline and calcium salts has been used in the treatment of pulp capping, pulpotomy procedure and also used as a liner for hypersensitive dentin. Kim et al. Studied the discoloration caused by the ledamix paste, where it is used as an intracanal medicament, and found this is mainly due to the presence of tetracycline in the formulation. It was suggested that if the paste is placed in the canal below the CEJ, it reduces the staining effects. Medicated gutta percha, it is introduced by Howard Martin, containing 10% iodoform and 10% tetracycline. Impregnated gutta percha intended to reduce the growth of bacteria inside the obturated root canal. This prevents the colonization of bacteria on the gutta percha points and within the root canals. Septomyxin 4, this contains 2 antibiotics, that is the neocycline and polymyxin B sulfate. Neither of this can be considered as ideal or substitute for use against the commonly reported endodontic bacteria because of their limited spectrum of activity, which is proved by Abbott et al. Antibiotics in regenerative endodontic procedure. So generally the regenerative endodontic procedure is a biologically based procedure designed to replace the damaged structures, including the dentin and the root structures, as well as the cells of pulp dentin complex. In immature teeth with necrotic pulp and open apices, regenerative endodontic procedure promote root development and apical closure. Most REPs include minimal to no mechanical debridement, relying on chemical debridement and on the use of intracanal medicaments to achieve disinfection. Intracanal medicaments in regenerative endodontic procedures. They are used as bi-antibiotic and triple antibiotic paste. Double antibiotic paste or bi-antibiotic paste includes 2 drugs, namely ciprofloxacin and metronidazole. Ciprofloxacin in the combination of 500 mg, which are available as Ciprobay and Cipro, which are effective against gram-positive and gram-negative organisms, and metronidazole 200 mg, which are available as Flagyl and Aniline, which are the nitramidazole group, which are effective against anaerobic bacteria. Triple antibiotic based, as we all know, it contains metronidazole 200 mg, ciprofloxacin 500 mg and clindamycin 500 mg. So metronidazole available as Flagyl and Aniline, which is anaerobic bacteria. Ciprofloxacin available as Ciprobay and Cipro, which are effective against gram-positive and gram-negative, and clindamycin, they are also effective against gram-positive and gram-negative organisms. Systematic antibiotic used in the treatment of traumatic injuries of teeth. So according to the International Association of Dental Traumatology, in this case of dental injuries among the young individuals, prevention of bacterial contamination is of major great concern, as the prognosis may be dramatically affected from mild to severe, particularly when the bacteria are able to access the site of injury and compromise healing. The inflammatory root resorption is one of the most undesirable complications associated with the traumatic injuries. Exclusion or limitation of bacterial growth during the healing phase is a logical approach to obtain the best outcomes in the management of traumatic injuries. Luxation injuries of permanent dentition, IEDT guidelines do not recommend the use of systemic antibiotics in the management of luxation of teeth with root fractures. However, antibiotic administration might be indicated at the discretion of clinician when the injury is accompanied by soft tissue trauma requiring intervention. Systemic antibiotics used in the treatment of traumatic injuries of different injuries, namely normal tooth injury, systemic antibiotics is not recommended. In case of tooth fracture, concussion or subluxation, luxation injury of permanent dentition, extrusion, in all these cases, antibiotics are generally not recommended. In case of replantation of avulsed tooth, that is, if the tooth come out of the socket by various reasons such as trauma or wrong tooth extraction, in this case the systemic antibiotics, mostly tetracycline and doxycycline, has been prescribed. Dental procedure which are at the high risk of bacteremia includes dental extraction, periodontal procedures like surgeries and scaling and root planing, dental implant placement, reimplantation of avulsed tooth, endodontic instruments which went beyond apex, endodontic surgeries, placement of retraction cords, placement of orthodontic bands, intraligamentary and intraosseous injections. Procedures at a low risk of bacteremia: restorative procedures, intracanal endodontic treatment and post placement and core buildup, placement of rubber dam, removal of partial dentures, orthodontic appliance and adjustments, taking oral impressions, oral radiographs and fluoride gel applications. Coming to the complications of antibiotic therapy. So, systemic antibiotic therapy is an adjunctive tool in endodontics when managing spreading the oral infections or safeguarding the medically compromised patients. However, its overuse or misuse presents a variety of complications ranging from acute life-threatening patient-specific reaction to broader public health challenges, which has been proved by Segura Iga et al. In the year 2017. So, according to Bansal et al. In the year 2019, because of the pulp chamber and the root canal system are entirely avascular once necrotic, systemic antibiotics are administered cannot reach the therapeutic concentrations within the root canal space to eliminate the biofilm. According to Muller et al. In the study done on 2025, consequently prescribing the antibiotics without definitive local treatment such as pulpectomy, root canal debridement or incision and drainage offers no therapeutic benefit while exposing the patient to substantial risks. Hypersensitivity and allergic reactions. These are the most immediate clinical risk of empirical antibiotic prescribing in the dentistry. Beta-lactamase. As the primary first-line choices for endodontic infection, these drugs has been frequently implicated in hypersensitivity reaction ranging from mild cutaneous eruptions, that is urticaria and pruritus, to severe life-threatening type 1 hypersensitive, that is anaphylactic reaction. Cross-reactivity. Mismanagement or inaccurate documentation of penicillin allergy can lead to dangerous cross-reactions if alternative agents like cephalosporins are introduced improperly. Gastrointestinal dysbiosis and superinfections. Systemic antibiotics indiscriminately alter the protective gastrointestinal microbiome, giving rise to secondary complications such as Clostridioides difficile associated diarrhea and oral and vaginal candidiasis. Clostridium difficile associated diarrhea. These are here the broad spectrum agents, particularly lincosamides like clindamycin, severely disrupt the gut bacterial flora. This allows to proliferate and release toxins, causing severe pseudomembranous colitis, leading to toxic megacolon or death. Oral and vaginal candidiasis. Here, the broad spectrum antibiotics can precipitate opportunistic fungal overgrowths, causing acute pseudomembranous candidiasis. Organ toxicity and drug reactions. Organ toxicity, example, hepatotoxicity and nephrotoxicity. High dose or prolonged empirical courses can impair liver and kidney function. Example, amoxiclav carries high risk of cholestatic jaundice compared to amoxicillin alone. Adverse drug reactions. Antibiotics can interact dangerously with patients' existing systematic medications. Example, macrolides, that is erythromycin, inhibits cytochrome P450 150 enzymes which can dangerously elevate the serum levels of drugs like theophylline or certain statins. Microbial and public health complications. Acceleration of antimicrobial resistance. So the global emergence of multi-drug resistant bacterial strains, that is the MDR strains, is significantly accelerated by routine overprescription of antibiotics for non-indicated dental conditions. So dentists are responsible for approximately 7 to 10% of primary care antibiotic prescription globally, a notable portion of which are clinically unnecessary. How complication leads to resistance. So bacteria exposure to unnecessary antibiotics can act as enzymatic degradation and target modification. Enzymatic degradation leading to production of beta-lactamases, example Streptococcus species or Porphyromonas species. Coming to the target modification, altered penicillin binding proteins in E. faecalis and ribosomal methylation. This both can lead to active efflux, that is upregulation of efflux pumps, example MEF-MEL genes, to actively expel macrolides or tetracycline, which ultimately leads to antimicrobial resistance. Complications of common non-indicated prescriptions. A primary driver of antibiotic complication is their use as a surrogate for definitive dental intervention or for conditions where inflammation rather than an active infection is the root cause. So coming to some endodontic diagnosis, we will compare the common prescribing error and the clinical sequence. First is the symptomatic irreversible pulpitis. Commonly prescription, we will be prescribing it for prescribing severe radiating pain, and here it generally comes ineffective as the pain is mediated by local tissue inflammation inside a closed intact pulp chamber. So antibiotics here in this condition provides a strong placebo effect but do not reduce pain or inflammation. So placebo here generally reveals the non-pharmacological management of pain. Symptomatic apical periodontitis. Here the drugs has been prescribed for localized pain on biting or percussion without swelling. Here the clinical consequences is generally ineffective as the periapical periodontal ligament is inflamed due to the necrotic debris escaping the canal. So the treatment requires the mechanical debridement, not the systemic medication. Localized acute apical abscess. Here we will be prescribing it for the intraoral localized fluctuant swelling without systemic signs, but here it becomes unnecessary since the primary clinical objective is to establish the drainage through the root canal or via the transmucosal incisions. Systemic antibiotics do not hasten healing if drainage is properly achieved. Prophylaxis for flare-up cases. Routine prescription is given to prevent the post-operative pain or interappointmental flare-ups. In this case, it becomes ineffective as the controlled clinical trials that systemic antibiotics have zero therapeutic impact on post-surgical and post-instrumentation outcomes. Antibiotic stewardship protocols. This is the primary and the most important protocol or procedure to be followed before prescribing a patient about the antibiotics. To mitigate these clinical and microbiological complications, modern endodontics has been strictly adhered to the antibiotic stewardship protocols, which is proposed by Muller 2025. Systemic adjunct therapy should be strictly confined to the cases where the infection has spread past the cortical plate or into the facial spaces, or where the patient displays systemic objective symptomatic indicators such as fever, that is the oral temperature greater than 38 degrees Celsius or 100.4 degree Fahrenheit, lymphadenopathy, tender palpable lymph nodes, trismus, inability to open the mouth normally, indicating masticatory space involvement, cellulitis or rapidly spreading diffuse facial space swelling, malaise or lethargy accompanying an odontogenic presentation, immunocompromised status or specific medical conditions requiring prophylaxis. Recent advances in antibiotics in endodontics. Nanoparticles. Incorporating the nanoparticles has been found to have broad spectrum of antimicrobial activity and less incidence of microbial resistance development than antibiotics. Nanoparticles generally ranges from 1 to 100 nanometer in size. They can be organic, inorganic, metallic and functional nanoparticles. Nano silver, gold, zinc oxide, magnesium oxide, calcium oxide and titanium oxide has been extensively used. Functionalized nanoparticles containing various reactive molecules and decorated with peptides or larger ligands have led to new possibilities of combating the antimicrobial resistance and potent drug deliveries. Nanodiamonds may offer unique advantages due to their favorable properties. like nano diamond gutta percha composite embedded with nano diamond amoxicillin conjugates, which can reduce the likelihood of the root canal reinfection and enhance the treatment outcomes. Nano silver coated gutta percha was introduced in 2008 by Iranian researchers to prevent the bacterial colonization in root canal space. Silver nanoparticles. Generally, among the nanoparticles, silver component in nanoparticles exhibit the higher and leading antimicrobial and antifungal properties, as they possess a multi-level mode of action. By electrostatically interacting with the cell membranes and the binding of thiol groups to the proteins, AGNPs are able to disrupt the cell walls and metabolic processes, inactivate the bacterial enzymes, and increase the cell permeability and generate the reactive oxygen species. More recently, it has been shown that the effects of antibiotics against a range of bacteria, including the antibiotic resistant strains. Combination of antimicrobial nanoparticles and calcium hydroxide. Studies have explored the concept of incorporating nanoparticles to provide the properties of existing medicaments, particularly calcium hydroxide. The combined calcium hydroxide and antimicrobial nanoparticle encourage the synergistic effect, collectively enhancing the antimicrobial property. Calcium hydroxide nanoparticles. Several studies has been found that the nano calcium hydroxide shows deeper penetration into the dentinal tubules, had superior antibacterial activity against the E. fecalis compared to the conventional calcium hydroxide used routinely. Furthermore, nano calcium hydroxide resulted in less reduction of dentin microhardness compared to the conventional calcium hydroxide dressing. To conclude, since the discovery of antibiotics 8 decades ago, the safer use has been revolutionized in the treatment of diseases, transforming once deadly diseases into the manageable health problems. To sum up, risk-benefit ratio should always be weighed before prescribing the antibiotics. Appropriate selection of patient will benefit the systematically administered antibiotics. The restrictive and conservative use of antibiotics are highly recommended in endodontic practice, but indiscriminate use in contrary to sound clinical practice. So coming to a journal study, use of antibiotics in endodontics, a critical review done by Jagdish Babu. Here, the endodontic infection, the local administration of antibiotics has been found to be more effective when compared to the systemic administration in a nutshell. Coming to a journal of use of antibiotics by Pramota, here, the amoxicillin alone or in combination with the clavonate is recommended because of better absorption and lower risk side effects has been proved. Lincosamides such as clindamycin are the drug of choice in case of confirmed penicillin allergy. So, these are the references. Thank you for watching this session.